Our next speaker is Professor Schaaf, the director and chairman of the Institute of Human Genetics in Heidelberg University Hospital in Germany. He will speak about another very complex genetic syndrome, Prader-Willi syndrome, from patients to molecules and vice versa, and the organizers who just played the record.
Thank you for the kind invitation, and thank you for giving me the opportunity to present at this important rare disease conference. My name is Schaaf. I am the executive chair of the Institute of Human Genetics at Heidelberg University in Germany. Today I want to present on Prader-Willi syndrome and related disorders from patients to molecules and vice versa. The history of Prader-Willi syndrome goes back to the 1950s when Andrea Prader, Alexis Lapart and Heinrich Willi first reported on 9 children with the following features: small hands and feet, abnormal growth and body composition, including small stature and early onset childhood obesity, hypotonia, and then followed later by insatiable hunger, extreme obesity, and intellectual disability. The condition was subsequently called Prader-Willi syndrome, or commonly referred to as Prader-Willi syndrome. This is a clinically recognizable condition, and clinical diagnostic criteria have been defined. There are major criteria that provide 1 point each, including infantile hypotonia, infantile feeding problems, rapid weight gain between the 1st and 6th birthday, a characteristic facial appearance, hypogonadism, which is hypogonadotrophic hypogonadism, and developmental delay, later intellectual disability. There are also minor criteria that account for half a point each, and those include decreased fetal movement, typical behavioral problems including stubbornness and manipulative behavior, sleep apnea, which can be a combination of central and obstructive sleep apnea, short stature, hypopigmentation, small hands and feet, narrow hands with a straight ulnar border, strabismus, myopia, thick saliva, speech articulation defects, and skin picking. Supportive findings may include, but do not account for any points, a high pain threshold, decreased vomiting, temperature control problems, scoliosis or kyphosis, early adrenarche, osteoporosis, some behavioral curiosities such as an unusual skill with jigsaw puzzles, and normal neuromuscular studies. The clinical diagnostic criteria were published by Holm et al. In 1993, and under the age of 3 years, 5 points are sufficient to make the clinical diagnosis. Over 3 years of age, 8 points are necessary to make the clinical diagnosis. But then later, and I'll go into more detail about this, once the molecular etiology of Prader-Willi syndrome was defined, it was recognized that not all diagnostic criteria may be needed in order to initiate molecular testing, and also that the sensitivities and the percentages of documentation for the published criteria vary from one criterion to the next. This was published by Günay Aygün in 2001. And this group also suggested new criteria to prompt DNA testing for Prader-Willi syndrome. They say from birth until the 2nd birthday, every child with hypotonia and poor suck during the neonatal period should be subjected to DNA testing for Prader-Willi syndrome. In kids 2 to 6 years old, those criteria should be met, plus global developmental delay should be present. Over the age of 6, excessive eating with central obesity, should be present, and over the age of 13 also the hypothalamic hypogonadism and or the typical behavior problems should be present. The molecular causes of Prader-Willi syndrome began to be unraveled in the early 1980s. David Ledbetter and others published in 1981 Prader-Willi syndrome as the first microdeletion syndrome. This is really when high-resolution chromosome analysis became available, and they showed that in many patients with Prader-Willi syndrome, a small piece of chromosome material is missing on chromosome 15q11. A couple of years later, it became obvious that Prader-Willi syndrome is an imprinting disorder when Butler and Palmer published in 1983 that the 15q deletion is always present on the paternal chromosome, and that the respective deletion on the maternal chromosome would not cause Prader-Willi syndrome. They had been studying chromosome 15 heteromorphisms, indicating that the deletion is always on the chromosome 15 that's inherited from the father. It took 6 more years until Nichols et al. Published the first 2 cases of uniparental disomy, meaning that Prader-Willi syndrome can also be present when both copies of chromosome 15 are inherited from the mother. So in order to explain this a little better, let's go into the basics of genetics and the basics of epigenetics. So Prader-Willi syndrome is all about chromosome 15. We have 2 copies of chromosome 15 which contain a region of DNA that's called the Prader-Willi syndrome region, and this is on chromosome 15q11 to 15q13. In that particular region that's important for Prader-Willi syndrome, only the paternal gene sequence is active. On the chromosome 15 that's inherited from the mother, the respective sequence is silenced or imprinted. And Prader-Willi syndrome only occurs when this region of DNA is missing on the father's chromosome, or also occurs when someone has 2 copies of chromosome 15 from their mom, but no such copy from their dad, and we call that uniparental disomy. There are a few genes within the region that are important, and those include 6 protein-coding genes and a bunch of small nucleolar RNAs. And you can see those genes here. In direct proximity to the Prader-Willi syndrome critical region, there is the Angelman syndrome region with the gene UBE3A. And for UBE3A and the Angelman region, the situation is quite opposite to Prader-Willi syndrome, because that is a condition that is caused when chromosome material is deleted from the maternal chromosome, because only the maternal copy of UBE3A is expressed in the brain. Now, my group and myself discovered in 2013 that point mutations in the MAGEL2 gene, which is one of the protein-coding genes within the Prader-Willi syndrome region, can cause a neurodevelopmental disorder that looks somewhat like Prader-Willi syndrome. In fact, it all started with a patient who presented to my clinic who looked very much like a child with Prader-Willi syndrome, with hypotonia, feeding difficulties, hypogonadism as a baby, but genetic testing for Prader-Willi syndrome remained negative in him. And that is true for most kids with this condition that I will talk about. Now, why is Prader-Willi syndrome testing negative in those children? It's because the Prader-Willi syndrome test checks whether the dad's copy of chromosome 15q11 is present. And it's absent in almost all of the cases of Prader-Willi syndrome, but it is present in children who have point mutations in the MAGEL2 gene. The condition that's caused by point mutations in the MAGEL2 gene was subsequently called Schaaf-Yang syndrome, so I will refer to this nomenclature from now on. And the abbreviation for Schaaf-Yang syndrome is SYS. So the type of mutation in Schaaf-Yang syndrome is very different from Prader-Willi syndrome because it's not a missing piece of chromosome material or uniparental disomy. No, it is single base substitutions within the MAGEL2 gene. How is Schaaf-Yang syndrome diagnosed? Because the mutations are different, you do need a different methodology for testing, and the appropriate testing would be gene sequencing. This can be either single gene sequencing for the MAGEL2 gene or could also be whole exome sequencing. Because the MAGEL2 gene is within the Prader-Willi syndrome critical region, that is an imprinted locus, once you show that a mutation is present in the MAGEL2 gene, the lab still needs to run an additional test to prove that the MAGEL2 mutation is actually on the paternal copy of that gene. There's a lot of clinical overlap between Prader-Willi syndrome and Schaaf-Yang syndrome, and we're trying to illustrate this here. In particular, in the neonatal period, the kids with Schaaf-Yang and Prader-Willi look almost alike. There are only subtle differences, and those include the presence of contractures of the small joints, especially the small finger joints, that are highly prevalent in Schaaf-Yang syndrome and very rarely seen in Prader-Willi syndrome. Additional differences include the early onset of hyperphagia and obesity in Prader-Willi syndrome, which is less pronounced and of later onset in children with Schaaf-Yang syndrome. Also, the prevalence of autism spectrum disorder is much higher in Schaaf-Yang syndrome than Prader-Willi syndrome. As of today, we are in touch with more than 250 cases with truncating mutations in MAGEL2, and we have been following those children and their families and their clinical manifestations over the course of years. There are familial cases with Schaaf-Yang syndrome. This is different from Prader-Willi syndrome, which typically occurs isolated in single individuals within the family and is not passed on from one generation to generation. But in Schaaf-Yang syndrome, due to the nature of the mutation, with the point mutations, those can be passed on from one generation to the next, and people will be unaffected as long as they have the mutation on their maternal copy of the MAGEL2 gene. But when a father passes the mutation to his children, then those will be affected because then they carry it on their paternal copy of the MAGEL2 gene. Let's talk a little bit about the clinical features of Schaaf-Yang syndrome. In infancy and childhood, they include low muscle tone, contractures, hypogonadism in many boys, undescended testicles, and then later we see the developmental delay, the intellectual disability, and the autism spectrum disorder. There are additional common features of Schaaf-Yang syndrome, and some of them are very similar to Prader-Willi, including sleep apnea. In Schaaf-Yang, they often have respiratory problems. In fact, sometimes they can be difficult and life-threatening. And then feeding problems during infancy, very similar to Prader-Willi syndrome. Here you see the hands of individuals with Schaaf-Yang syndrome showing the contractures and also the tapering of the fingers, which is quite distinct and makes this a recognizable syndrome. During adult life, the phenotype changes a little bit, and I will refer to this publication by Felix Marbach and his team that was published in 2020. What becomes evident as kids and individuals get older is that overeating, obesity becomes more prevalent, and also the neuropsychiatric phenotypes and the sleep problems become more prevalent during adult age. Here in Table 3 you see the behavioral difficulties, including high levels of anxiety and social withdrawal, sometimes also manic behavior and aggression, and some overlap with the Prader-Willi syndrome phenotypes like stubbornness and temper tantrums. So our perspective of Prader-Willi and Schaaf-Yang has shifted a little bit, such that Schaaf-Yang individuals include a lot of the phenotypes that we also see in Prader-Willi. There do remain some differences, and in fact, surprisingly, some of the cognitive and behavioral phenotypes of Schaaf-Yang are more pronounced than in Prader-Willi syndrome. from Prader-Willi syndrome research. In fact, most children with Prader-Willi syndrome have a deficiency of growth hormone, and we also see this in Schaaf syndrome. Growth hormone treatment has been FDA approved for Prader-Willi syndrome since the 2000s, and the benefits go much further than just longitudinal growth. They actually shift body composition and energy consumption. They lead to additional muscle strength and exercise tolerance, and endurance and stamina for the affected individuals. We have done this off-label in children with Schaaf syndrome, and you can see the remarkable effects on this child. There are only a few months between one and the other picture, and you see how the whole body composition actually changes. This has been more systematically reviewed by Niels Hiebach from my team and others, and that was published in 2021, and I will just refer to this publication showing the remarkable effects of growth hormone also on children with Schaaf syndrome. It does have a positive effect on body mass, and generally the perception of the affected individuals and their families is very positive, because you can also see the effects on strength and stamina in children with Schaaf syndrome. Now, are there additional things that we can learn from Schaaf research that may possibly also translate to the Prader-Willi syndrome field? In the neurons of individuals with Schaaf syndrome, we find an upregulation of the mTOR pathway. We did this based on studies generated from skin cells of affected individuals with Schaaf syndrome that we reprogrammed to become induced pluripotent stem cells and then differentiated them into induced neurons. My PhD student Emmeline Crutcher showed in a publication that came out in 2019 that neurons of individuals with Schaaf syndrome look different, and that this molecular and morphological phenotype can successfully be treated with rapamycin that really rescues those manifestations. One important question is whether this also works in a living organism, and we have done most studies to follow up on this. This was funded by the Foundation of Prader-Willi Research. On the treadmill, MAGEL2 knockout mice get exhausted earlier and they travel less. And we have shown that treatment with rapamycin improves the ability to walk on the treadmill and improves the endurance of those mice. But unfortunately, many other phenotypes of those mice were not rescued by rapamycin treatment. There are additional new lines of research in the Schaaf lab that relate to MAGEL2 and Prader-Willi syndrome. We're trying to approach this in a trans-species approach, looking at both neuronal cell culture, MAGEL2 knockout mice, and new rat models for Prader-Willi syndrome and Schaaf syndrome, and then translate it back into human patients. We know that MAGEL2 knockout mice are deficient in oxytocin, which is a hormone that's important for social behavior, and this is a line of research that we're following up on. In fact, I have a very talented postdoctoral researcher, Dr. Ferdinand Altheimer, who's leading the translational investigation of oxytocin in Schaaf syndrome and Prader-Willi syndrome. As part of this research, it will be very critical to assess whether there are critical time windows for oxytocin treatment and what would be the best time windows to treat individuals in order to rescue feeding behaviors and social interaction behavior. And there are also ongoing studies in the context of Prader-Willi syndrome in young children with Prader-Willi syndrome that are currently ongoing in France, and we are anxiously awaiting the results of those studies. So, in summary, I showed you that Prader-Willi syndrome is a neurodevelopmental disorder caused by lack of maternally imprinted sequence on chromosome 15q11. Schaaf syndrome is a molecular and clinically related disorder that is caused by point mutations in the MAGEL2 gene within the Prader-Willi syndrome locus. I also showed you how recombinant growth hormone proves to be beneficial both in Prader-Willi syndrome and Schaaf syndrome. Additional lines of investigation that are currently ongoing both clinically and molecularly, include the investigation of oxytocin on cell models, mouse models, and human patients with Schaaf-Yang and Prader-Willi syndrome. And with this I will close, and I would like to thank my entire team, my lab members here at Heidelberg University, and also my former lab members at Baylor College of Medicine in Houston. I also want to thank the funding agencies, especially the Foundation for Prader-Willi Research, and the many, many patients with Prader-Willi syndrome and Schaaf-Yang syndrome that continue to be the inspiration for everything that we do. Thank you very much, and I do look forward to your questions.